understand how radiologists interpret images. So anyway, so we're going to continue part two, which is assessment and interpretation of chest X-ray. This is both for pulmo and cardio, and of course, we're going to discuss along the way. It's just going to be a mix of anatomy, localization of lesions. I will also be introducing radiographic terminology, such that when you see requests, when you see results of X-ray, you would know what the radiologists are referring to. And hopefully, in some of you radiologists, then we're also going to discuss some technical factors which would help you in the interpretation of radio images. Then actually what I did was to also mix with a number two common conditions that you would be able to diagnose using X-ray. And of course, we're going to discuss a little about chest X-ray requests. So let's proceed now with a recap of what we have discussed last time. So just to give an just to refresh you. So we have the frontal views. When we talk about frontal views, it's about PA or AP views, whether it is done in supine or position or upright position. When erect and upright are used interchangeably in radiography. So this is the PA view. This is the AP view. I will be discussing later the difference between both. Lateral view. Then, of course, we have the lateral decubitus position, wherein the patient is placed on the sides while lying on the X-ray bed. Then apicolor, we have the apicolordotic view. And of course, we also have discussed last time the ABCs of chest X-ray assessment and interpretation. So just a recap, as you see, the problem with radiology, with the radiography or X-rays, that the structures are superimposed, so you would not be able really to determine what part of the chest is involved in a certain condition, not unless you actually do a lateral view or other views. Actually, it's not only lateral view which is available for us. We can also do an oblique views, which are actually quite seldom used lately, but at times we still use it. But I'm not going to discuss it with you anymore, because usually if oblique views are requested, usually the radiologist would suggest it in their remarks. So that would already help you in making a follow-up request or an ancillary request. Anyway, I guess we have already discussed breathing. And as I've mentioned before, the problem if you use the different lobes is that there's superimposition, such that what we usually do is when we refer to lesions, we all just mention upper zone, middle zone, and lower zone, and it's basically the hilar region, which is the cutoff. I mean, that's the level wherein we divide the upper zone or lower zone. That would be the reference point. So upper, middle, lower zone, or basal. Then we have the apices. Usually the apices of the lungs would be around at the level of first to second intercostal spaces, or involving actually the thoracic inlet, the part of the lungs which is actually seen at the thoracic inlet. Then as a recap also, we have the perihilar region or central region. Then we have the peripheral or lateral, and I've discussed with you the significance of which it will make us clinch more the diagnosis in certain conditions. So as a recap, we have the paratracheal area, we have the paracardiac areas, cardiophrenic areas, and costophrenic angles. These are actually widely used locations or areas or regions when radiologists would describe lesions as to location. Then we have the retrosternal, retrocardiac space. Then also we have the left posterior costophrenic spaces, the right posterior costophrenic spaces. I'm sorry for a while. Anterior costophrenic for a while, for a while. Okay, sorry. Then local, we also discuss um, how we localize pulmonary lesions. So basically, after we do a frontal X-ray examination, whether it's posterior, anterior, anterior, posterior, we just add lateral view to help us in the localization of certain lesions. So this is the frontal, whether AP or PA, and the lateral view. And basically, what actually we use here to delineate between the middle and upper lobes would be the fissures. So we have the right and left major fissures or oblique fissures, and at the same time, we have the right minor fissure. So these are basically the three main fissures we're using to localize whether which lobe is affected. So of course, on top of the frontal, we have to do the lateral views so that we would be able to know whether it's upper lobe, middle lobe, or lower lobe. In particular, if we're referring to the right lung. When it's left lung, so it's just only upper lobe and lower lobes. So on top of the lobar lesions, we also have segmental lesions. And I discussed yesterday with you that at the right lung, we have 10 segments. On the other hand, on the left lung, we have 8 segments, so 18 segments all in all. Please remember that, because at times that comes out in your board, in your PLE exam. So after examination of the lungs and pleural spaces, out of the lungs, we discuss pleural spaces. So I think basically what's significant with the pleural spaces is that some of the most common conditions which you encounter in the clinical practice, such as pleural effusion, actually is located in the pleural spaces rather than the lungs. Then we have also here a case of pneumothorax, usually seen in cases of trauma, wherein the difference between both is that pleural effusion, because it's fluid, it's opaque, while pneumothorax, because basically it's about air, therefore it's lucent. Then we have a case here of a mixture of pleural effusion or hydrothorax, the other term we use. If it's blood, then we use hemothorax. Then this one is actually a case wherein you have a mixture of fluid and air. Laterally, if you notice, there's a lucent lesion. There's lucency at the periphery of the left hemithorax. On the other hand, there's a level of opacity at the lower portion of the hemithorax left. So this is actually a case of pneumohydrothorax. So I guess we've also discussed airway, if I'm not mistaken. I don't know if we left off from this portion, but nevertheless, I'm just going to give a recap. So basically, what the yellow line now shows is your thoracic portion of the trachea. So that's your main airway. Then on the right side, we basically have the right main bronchus. So your trachea splits into the right and the left main bronchus. And I guess I've discussed yesterday the difference between both. And the green one there actually represents the carina. At times, the radiologists would mention the carina. So that's the carina. It's quite significant in cases, usually, or it's commonly used in cases wherein you have endotracheal tube, because the reference for whether the placement of the endotracheal tube is correct or not would be the carina. So that's why in cases wherein the patient is intubated, the carina is quite significant or important. So as we mentioned before, the right main bronchus is usually wider and shorter. But what I want to what's important to know actually, the difference between the right and the left main bronchus is that the right main bronchus is never higher than the left main bronchus. When the right bronchus is higher than the left main bronchus, that means there's a pathology, or usually we have a case of right upper lung atelectasis, which resulted into the elevation of the right main bronchus. Okay, so this is actually a classic X-ray of a case of extensive pulmonary tuberculosis, wherein if you can you see my arrow? Can you see the arrow?
Yes, the
Okay, okay. So this is a case wherein the trachea is markedly deviated to the right. If you notice, this is the trachea. It's markedly deviated to the right. And this is actually a result of pulling because of the collapsed lung in this area. So if you also notice, the right main bronchus and the left main bronchus are of equal level. And this already is indicative that there's a possibility of a cicatricial atelectasis, which is usually associated with pulmonary tuberculosis. So basically, this is actually more of a case of a sequelae of pulmonary tuberculosis, wherein both hyla, it's not actually, though it's the right hyla is elevated, and the left hyla, though it's equal to the right hyla, but it's some sort of cicatricial atelectasis is also happening in the left hyla, such that the orientation of the hilum supposed to be is downward. If you notice, the distal end of the left main bronchus here is upturned, so it's directed upwards instead of downwards. So there's also some sort of atelectasis going on here. Am I fast, or are you? Do you still get me? Am I fast? Is my pace okay?
Okay lang man, Doc.
Okay, sige. Just inform me if you cannot. Just feel free to interrupt me if you cannot understand if I'm going too fast. Okay. So this is okay. Wait for a while. For a while, I want to see your. How is it already? I guess we have discussed this one last time already. Rogen Maria Junto. Did I get your name right? Rogen Junto.
Yes,
Are you
Doc.
around? Okay, good evening. Can you please describe what's wrong in this X-ray image? Just try to, okay, let's start with the density. What's the abnormal density here? Is it opacity or lucency?
There's opacity in the right
Yeah,
lung.
correct. So there's the right lung is basically the entire right lung is basically opaque. Okay, there's an opacity there. What else do you see?
The trachea, Doc, is deviated, I think.
Okay, the trachea is deviated to the right. The hilum, both hyla, can you identify? Can you still identify the hilum? I mean the right and the main left bronchus. Though you cannot see here, actually, it seems here that the right bronchus, main bronchus, is quite elevated also. What do you think is the problem in this case? What happened to this lung? Why does it look that way? What do you think happened to the lung? Is this a case of fluid? Is this the case of collapsed lung? Is this a case of pneumonia? What do you think?
I think the right lung is probably collapsed, Doc.
Okay, correct. So basically, the right lung is collapsed. That's why there's ipsilateral. Ipsilateral meaning on the same side. There's an ipsilateral tracheal deviation because it's collapsed. So bali nag-shift to the right. Actually, it's just not just only the trachea, but the rest of the mediastinal structures, including the heart. That's why it looks so opaque, because there's on top of the collapsed lung, which already is usually opacified. Superimposed here actually are the um, opaque also na heart and rest of the mediastinal structures. That's why it's so white, because there's a shift. So basically, almost the entire lung here is actually collapsed. Okay, thank you. So this is actually a case of right lung atelectasis. Please remember the word atelectasis for collapse. This is commonly used. Next, we have a case here actually of pneumothorax. If you notice, this area is lucent and it is devoid, meaning you cannot see pulmonary vessels here. That means that the lungs is collapsed and that the pleural space here is almost filled with air. That's why it's hyperlucent or very lucent. So I think this one stands for the collapsed lung. So this is a case actually of a massive pneumothorax with passive atelectasis or passive collapse of the left lung. So one of the things also that we use to describe pneumothorax would be lucency or hyperlucent area, devoid, or meaning there's an absence of pulmonary vascular markings. Because there's absence of pulmonary vascular markings, that means that you don't have the lung parenchyma here. Though not all the time wherein you have absence of pulmonary vascular markings, that it not all the time that it means pneumothorax. We also have emphysema wherein there is sparsity or basically nag-decrease ang pulmonary vascular markings. So this is actually a case of tension pneumothorax. If you notice, the heart, most ideally in a normal X-ray, most of the content of the mediastinum, especially the heart, it should be more placed on the left side. But if you notice, there's shifting already or displacement of the mediastinum, including the heart, to the right, as well as there's already a shift of or displacement of the trachea to the right. So this is a case of tension pneumothorax. When you see this one, this is actually already an emergency. So I hope you would be able to identify this when you see it in the field in the future. Nevertheless, there's actually a pitfall here, because there are cases when your very large bullae, I'm sorry, I don't have an image here, but please check bullae, bullae. Can also present it with very large hyperlucent areas, but that those bullae does not need CTT or chest tube insertion, because if you do that, you would be doing more harm because it would lead to pneumothorax. I'm sorry, I have not prepared that, but I hope in the future, I don't know if I can make supplementary lectures for you to be able to, so that I would be able to explain more the difference between the two. But what's important is that when you see this one in the field, especially if there's deviation of the trachea, that's already called tension. That means this is an emergency case that you should already be referring to the surgery department. Okay. I'm sorry, I have to escape again. And Irish Celestino. Do we have Irish here? Irish Celestino. Is Irish around? Irish.
Doc.
Yes, yes. What do you think
She's
is the problem here?
Doc. This
Yeah?
is Carmine, Doc. Irish is actually here, Doc, but unstable do ang internet niya because she's just using data, Doc.
Okay, sige na lang. Okay. Let's just proceed with Ann Tortosa. Ann, are you around? And can you please describe what's wrong with this issue?
Hello, Doc.
Can you describe what's wrong? What's abnormal in this image? Can you see opacity or lucency?
Opacity, doctor, sa left lung.
Okay, so basically the left lung is filled with an opacity. And can you describe more about the airway, the trachea? Is it displayed to the right or to the left or at the midline?
I think to the right, doctor.
So it's displayed to the right. So you have basically an opacity, homogeneous opacity. Homogeneous opacity is in the entire left lung with tracheal deviation to the right or contralateral to the opacity. Then if you notice the mediastinum here, if you notice the heart and the mediastinal structures are also deviated contralaterally or to the right. What do you think is happening here? What do you think is this case?
Atelectasis of the left lung, doctor.
Do you think this is an atelectasis?
Or
If it's atelectasis, if nag-collapse ang imo nga lung, ang imo nga mediastinal structure or heart, diin magpakadto dapat towards that abnormality or away from that abnormality. Kung nag-collapse, abe.
away.
Kung
Towards
nag-collapse,
doctor.
kung nag-collapse ang lungs mo, let's say nag-collapse ang left lung mo, ang imo nga mediastinal structures or your heart, di ba more on the left? Will it go more to the left or will it go more to the right kung nag-collapse siya?
To the left, doctor.
To the left, okay. Kaya nag-collapse siya, di ba? So naggamay ang volume niya, ipsilaterally ma-displace. So in this case, is it an ipsilateral, meaning same side? Nagpakadto sa left ang iyang heart or nagpakadto sa right?
Pakadto sa right, doctor.
So nagpakadto sa right. So kung nagpakadto sa right, there must be something pushing it to the right, di ba? Kaya kung atelectasis or collapse, ginapull siya. Pag ginapush away siya from the lesion, meaning may ara na nag-occupy sa ina nga portion that pushes it contralaterally. So what do you think is the case here? What's the possible? Yes?
Is it pleural effusion, doctor?
Yeah, okay. This is actually a case of massive pleural effusion. If you notice, there's contralateral deviation. So meaning ang fluid nag-occupy sa left hemithorax. That's why it's pushing the heart, the mediastinal structures and trachea away from that area filled with fluid. Actually, this can also happen in very large mass lesions. But with the way that the opacity here is homogeneous, it is more indicative of the presence of fluid. Kaya kung ini siya mass lesion, usually more heterogeneous or inhomogeneous, meaning hindi amo ni ka-equal no ang iyang opacity. Nevertheless, actually, this is a case of pleural effusion with tension. We call it tension if there is actually a contralateral displacement of the airway or primarily of your trachea. And cases with tension actually needs immediate care. Okay. So this is actually just to show you the difference between the two images. So on this one, can you see my arrow? Can you see the arrows? I mean my cursor. Can you see it?
Yes, Doc.
Okay. So on the right side, if you notice, again, just a recap, the difference between the two. This one is atelectasis. There's an ipsilateral because naggamay ang lungs, ginpull niya ang trachea towards it. Kaya syempre nagkupo siya, di ba? And even the mediastinal structures. On the other one, you have an opacity here because nagpuno ni siya sang fluid. So ginpush niya contralaterally ang airway kag mediastinal structures. So that's one way to determine whether it's atelectasis or it's pleural effusion. Now, let's proceed with your D, disability deformities. Actually, this more refers to the skeletal structures. Usually what we monitor actually or what we assess here in the skeletal structures would be primarily the presence of fractures, especially in cases of trauma. Though at times we would be able to also to identify some pathological conditions. Example, possible presence of erosions, lytic lesions, or sclerotic lesions in the bones. But nevertheless, usually when we're presented with this, especially in cases of trauma, we also at the same time assess the ribs and other skeletal structures. It's also part of the assessment of an X-ray. So basically, if you notice, this is a child wherein you have multiple rib fractures at the lateral aspect of the ribs. Then you also have fractures here at the posterior segment of the ribs. And actually, there's a suspicious old fracture at the anterior ribs. Okay, so this is just an image wherein I'm showing you the three parts or three portions of the ribs when radiologists would describe the ribs in an X-ray. So usually we refer it as there's a fracture at the lateral angle of the second, third, fourth, fifth, sixth right ribs. Then there's also a fracture at the posterior segment. So this one would represent the posterior segment of the ribs, and a possible old fracture at the anterior segment, the one that's less seen. So amo na siya ang ini siya amo ni siya ang anterior. But nevertheless, I'm going to show you later more clearly. So when we talk about the ribs, we have the anterior segment. So that's an example of the anterior segment. Ang sakbangan, ang mo siya fully makita. Okay. Then we also have the lateral angle. So these are the portions of the lateral angle. I'm randomly showing you. So bali amo na siyang sa lateral ang part nga nag-angulate no, ang ribs ta. Then of course we have the posterior segment of the ribs. So this one is the one that you really fully see well. So on its entirety, ang posterior segment among makita mo. So what's important actually also when you assess the ribs would be you should know how to count it. So basically, when we count the ribs, this is how we do it. Okay. So this is the first rib. So the anterior rib will be this one. The first anterior rib, the second anterior rib, the third anterior rib, fourth anterior rib, fifth, sixth, seventh, eighth anterior rib. Okay. Then when we count the lateral angle, basically, when we count the lateral angle, we start with this portion. So that's the first lateral angle, the second lateral angle for the right. This one is the third, fourth, fifth, sixth, seventh, eighth. Posterior. And I'm now discussing this with you because in the long run, you would encounter fractures wherein the radiologist would be describing where the fracture is located on what rib is involved. So you have to know how to count the ribs. So when we talk about posterior, we refer to this segment. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So if you notice for the anterior angle, what you just see is 1, 2, 3, 4, 5, 6, 7, and the most 8. But for the posterior angle, you would see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it doesn't mean that if you see 10 posterior angle, you would be able to 10 posterior segments of the ribs, you would be able to see at the same time 10 anterior segments of the ribs. So I'm telling you this now because this will help you later in how you assess cardiomegaly or how you technically assess if the image is of good quality. So just a recap. So this is second, third, fourth, fifth, sixth, seven, 8, 9, 10, 11. That's how we count it. So this one, actually, can I call on Alisa Marie Amihan? Alisa Marie
Good
Amihan.
evening, Doc.
Good evening. Can you please identify where you can see the fractures at the right side of the hemithorax? You have 3 fractures there as pointed out by
Yes,
the
Doc.
arrow. Can you please
The
identify what? Come again.
The third part, Doc. Third posterior, third, fourth, fifth.
Count again. Count again.
Fourth, fifth, and sixth, Doc.
Correct. So we have this one is the first, second, third. So this one, the fractures here primarily involves the fourth, fifth, sixth posterior segments of the right ribs. Thank you. Then
Thank you,
Andrea is around. Dicena, I'm
Present,
sorry,
Doc.
Andrea Dicena. Can you identify the fractures at the left side?
Third, fourth, fifth, sixth, seventh, and eighth, Doc.
Yeah, precisely. So you have fractures involving the posterior segments of left ribs from from second rib to the eighth rib. Very good, thanks. Okay, now we're going to proceed with the other skeletal or osseous structures. When we talk about osseous structures, that's just equivalent to skeletal structures, or when we talk about osseous, we mean bones, okay? So this one is actually your clavicle, so both sides of the clavicle. This one actually is your scapula. This one is your acromion. This one is your acromion. This one is actually your humerus, and this is actually the head, while this one is the proximal shaft of the humerus. When we talk about the spine, basically, actually, the spine is made up of 4 region. We have the cervical, which you only see the lower portion of the cervical spine when you do a chest X-ray. You have the thoracic. When you do chest X-ray, basically you should be able to identify all the thoracic vertebra from T1 to T12. And then you have the lumbar. You just see the upper portion of the lumbar spine. So usually you just see L1 to L3 when they adequately collimate. When they do a good X-ray, you just see just 1 or 2, the first upper 1 to 3. But basically, you should see all the thoracic from T1 to T12. So this is actually your spine. So basically, this represents your vertebral bodies, the square here. And this one actually that you see here represents actually your spine or the spinous process. So now, what type of chest X-ray should be requested to check the osseous structures of the hemithorax? Does anyone here know? Let's say nag-trauma, na-aksidente, then you actually want to see if may fracture. Though you can see it in the usual frontal X-ray, the regular frontal X-ray, whether PA or AP view. There's actually a specialized view wherein you can, because we changed some technical factors, you are able to assess better the skeletal structures or the bones. Anyone has an idea? If none, can I call on Arlo Lamis? Do you have any idea what you can request if ever you have a case of trauma wherein you want to assess the ribs?
Doctor, good evening, Doc.
Good evening. Do you have an idea?
No
What you
idea,
can...
Doc.
Okay, no, never mind. It's just okay. So actually, what you can do is you can request for a chest Baki. So let's say na may patient ka mo nga trauma, at first, you request for a PA view. Pag hindi siya katindog, then you request for an AP view. However, if nagaduda ka sang fracture, later, let's say kung makita naman actually nato no sa usual nga frontal x-ray, but if you may mga fracture nga hindi ka sure kung may fracture gid, you can request for an ancillary or an additional x-ray request of the chest. That would be your chest Baki. The spelling would be such as this. So this is actually a chest Baki view. If you notice, hindi masyado makita ang lung parenchyma. It's over-penetrated, but basically mas klaro dere ang imong skeletal structure. So please remember chest Baki when you have trauma patients wherein you want to delineate if there's fracture or not. Then let's proceed to the last. That would be exposure or everything else. For the exposure or everything else, so actually we have assessed already the airways, the lungs, at the same time the ribs. Now, when we talk about everything else, one important component actually here would be your soft tissue component. So we just don't look at what's in here, what's within the hemithorax. We also look at all the soft tissue component, including parts of the abdomen. Usually in radiology, when we refer to the thorax, we refer it as the right hemithorax, left hemithorax, right hemi-abdomen, left hemi-abdomen. When you do a chest x-ray, you only see usually the right upper hemi-abdomen and the left upper hemi-abdomen. So you check also all of this. What's included in the image should be checked also, not only the lungs. So in particular, I would just like to point out some areas where we commonly were in areas which lesions are commonly located, para kung makita nyo ang amon description, you would know where to find it. So we have the lower cervical region. Cervical, of course, that stands for the neck. So this is the lower cervical region. This is the left lower cervical region. Then you have the supraclavicular area. So this is the clavicle. So the soft tissue above it would be your supraclavicular area. Usually you would find enlarged lymph nodes here in cases, especially when you have cancer. Then this one we refer to as your axillary. Of course, you know the axillary area. And then when we refer to the lateral chest wall, basically we refer to this portion. And of course, what you have also would be your breast shadows for the female. At times, males also would have breast shadows. And at times, some females, hindi nyo masyado makita naman ang ilang breast shadow, no? So, when you see breast shadows, don't assume all the time that it's female. When you don't see breast shadows, don't assume all the time that it's male. You really have to see the labels in the chest x-ray. So of course you have the upper hemi-abdomen. Now, this is a case actually of how important also to assess your soft tissue component. If you notice, you have a breast shadow here, and at this portion, you don't have a breast shadow here. So by this, most often you can deduce that this patient actually had mastectomy. And of course, usually they do that when you have a carcinoma or cancer of the breast. And with this, it also already gives us an idea that we should check thoroughly for possible metastasis. At the same time, we're also going to check the bones if there are lytic lesions associated with carcinoma. So when we see actually chest x-ray, it's important also when we assume or we know what the patient, the admitting impression or the condition of the patient, whatever disease entity that the patient is having, it will help us direct to the abnormalities that we should be more closely looking at. So this one actually, if you notice, at the upper hemithorax, if you notice, there's a mass here. So though actually you can already see this at the hemithorax, but actually this soft tissue mass is actually a thyroid mass which extended if in the retrosternal area. So you know that you have a sternum here. Then of course you have a mass here, more on the left side. That's why your trachea is deviated away or laterally, displaced laterally. Kaya ang mass mo already nga nag-grow, i-displace ng trachea to the right. So this one actually is a thyroid mass that extended from the upper cervical area into the retrosternal space. So this is also something that you also have to recognize, especially when patients, when you have trauma patients or patients who underwent CTT for pneumothorax or pleural effusion or hemothorax. So what happened here is that if you notice there's lucency here, this is actually a case of subcutaneous soft tissue emphysema. Please remember this term because you would commonly encounter this one in cases of trauma. And may I ask, does that tabat? Are you around?
Yes, Doc.
Why do you think that this, can you describe the abnormality here in the soft tissue? Can you describe? What's the problem here? Is it opacity or lucency? The soft tissue. What do you think is the problem here?
I think the opacity.
Basically, when you talk about soft tissue, it is normal opaque, right? Because diba may fluid content ang soft tissue. So basically, it's more of opaque or normally opacified sila. With that, what do you think is the problem here? Is it the opacities or the lucencies here? Normal siyang ang soft tissue nga amo ni siya kaitom. Normal ni. If you recall the images I've been showing you, anong colors ang lateral chest wall? Let's talk about the lateral chest wall. Anong normal nga colors ang lateral chest wall? If you can recall the previous images that I've shown you. Is it
White.
opaque or lucent? White. So if it's white, it's opaque.
Yes,
The lateral chest wall is opaque because primarily, di ba, ang cells is made up of fluid. Most pila, I'm not sure if it's around 70% fluid. That's why it would appear opaque. Given that, so what do you think is the problem here with the lateral chest wall? Ano nga density ang abnormal diri na?
Maybe, Doc, there is the presence of air.
Yeah. So because may presence ng air, di ba? When we talk about emphysema, that means there is air. When we talk about subcutaneous or the other term for air sa radiology and any other medical condition is usually emphysema. Okay. So in this case, you have soft tissue or most of effort in radiology is subcutaneous because it is below your dermal layer, usually affecting your subcutaneous layer. But this one actually just does not only involve the subcutaneous layer, but also the deep soft tissue, the intramuscular layer. So you have air here. So for anong problema ta? Is it the lucency or opacity? Kung air, anong color gani isang air sa density ta? Ito mo
Dark, Doc.
dark. So what is the radiologic?
Lucency.
So basically, the problem here is actually lucency. If you notice on top, nga nag-lucent siya, nag-thicken siya because air is already being interspersed with your soft tissue, no? So nagdamol siya because nag-sit in ang air sa iyang soft tissue. So please remember the term emphysema for air, and air is lucent. Okay. So this is a case of soft tissue emphysema. At times that your patient have this one, and well, what we do is we have to identify the most important lines here, and we part of the assessment actually of chest X-rays with line would be to determine whether these lines or tubes are in place. So this one is actually a case of a patient with atelectasis. If you know why I'm saying that this is atelectasis, because the trachea is basically deviated to the left, so ipsilateral to the opacity. And the reason for this atelectasis actually is the displaced endotracheal tube, which is in which the distal tip is actually placed at the right main bronchus. So nadulaan sang oxygenation ang left main ang left lung because ang imo nga tube atoya tanan sa right mo nga lung. Kaya ang tube mo na sobrahan nila imbis nga above sa tracheal level lang nagsalod na sa right main bronchus. So wala na may nagsulod nga hangin sa left main bronchus. That's why this patient had atelectasis. So actually it's not really clear here, but the carina should be here. So supposed to be this tube here should be placed way above the carina at around 2 to 3 cms from the carina, at least. So that's the tube. Now, this one here, we have a very small tube here. So this one seems to be from the esophagus and to the right side. Does anyone have idea if what kind of tube is this? Can you mute the Charina? Charina Eliaga. Good afternoon. Charina, what do you think the tube is? I think this tube is?
Wait.
This is actually coming from the esophagus, not the trachea, because it's very small. So this is actually coming from the esophagus. So what tube do you usually see inserted from the level of the esophagus down? Ano ganing tubo nga ginausarta, nga gina-inserta through the esophagus? What do you call that? Actually, ginapaagi na siya sa tube, as a nose. So this is actually a nasogastric tube. So meaning from nasogastric, that means that this one should be inserted through your nose and it should end up into your gastric area or your stomach. But as you well know, your stomach is at the left side. So what happened here is that your nasogastric tube, instead of the tube ending in your stomach, it ended up into your left lower hemithorax or right lower hemithorax or right lung. Meaning, sining nga ang nasogastric tube nagtalang, instead makadto sa esophagus, pakadto sa stomach, ang tube nagkadto sa esophagus, pharynx, nagkadto siya dayon sa trachea, pakadto sa right main bronchus, and out into piercing ang iya nga and piercing into your right lung. So actually this is our displaced tube, nasogastric tube. Nevertheless, as just to give you a summary, that there are a lot, we also assess the placement of the tubes using chest X-ray. So kung ang pasyente nyo may mga CTT or mga central venous catheter, and you want to assess the placement, you use X-ray, chest X-ray to assess them. Now let's proceed to the circulation or cardiomediastinum. So we're now proceeding actually to the cardiology portion. Can we have a 2 minutes break? Okay lang sa inyo?
Yes, Doc.
Okay, what time is it? Dali lang. It's 6:25. We're going to go back at 6:28. Stretch out, ani, pang-update ka mo, ani, dali lang. Carmine? Carmine?
Yes, Doc.
There's 81 right now. Sinong duwa ka absent?
Doc, actually, there are a lot of
Tatlo.
them nga at chat, Doc, nga they're going in and out of Zoom, Doc.
Okay, so as of the moment, wala man may absent. Okay man
Wala
tanan.
man, Doc. Naka-go in man
Unstable
sila,
lang.
Doc. Yes, Doc. Super, Doc.
Yeah, actually, yung law ay man gid ang line. Nevertheless, okay, can we proceed right now? Okay,
Yes,
let's go
Doc.
back. Okay. So before we proceed to the cardiomediastinum, is there a question sa pulmonary portion? So far, are you getting? I mean, kahit pa paano, may ma-pick up man ka mo sa lecture, kahit pa paano, may maintindihan man ka mo, Jutay, about X-ray of the chest?
Yes,
Yes, Doc.
Anyone? Wala gid. So far daw, okay. So far, wala man question. Ma-proceed na ta sa cardio. Okay ta?
Questions, Doc.
Yes, okay. May question? Ano question? I'm sorry. Alcida.
None,
Hi,
Doc.
Doc. Is it if a
Yes, Doc,
copy of
but I
Alcida?
asked for PowerPoint, Doc, if later.
Okay. Okay, sige. I don't know if halos wala ni words tanan, pero I hope, sige. Para at least part actually, because most of we're discussing here is anatomy. Sige. Anyway, let's now proceed to circulation and cardiomediastinum. But prior to that, I missed discussing with you a very important principle of radiology actually when we talk about densities. And this is actually what we call the silhouette sign. Basically, if you notice, this one is actually the heartbeat. So this one, somehow you're just seeing the silhouette of the heart or the cardiomediastinal structure. Okay. And actually, the loss of this silhouette of the cardiomediastinal structures or loss of silhouette of any of these structures, whether it be on the periphery, but most likely when we refer to the silhouette, actually we refer to the cardiomediastinal silhouette. When we refer to the loss of cardio, that means that there's an ongoing pathology. In this case, actually, we have ang aton nga pneumonia usually would present as an opacity. Why would a pneumonia present with an opacity? Wild guess. John Mark Mundia. Can we have John Mark Mundia? Why do you think a pneumonia would present as an opacity? Why not lucency? John Mark
Good evening,
Mundia.
Doc. Hello.
Good evening.
Yes, Doc. Good evening, Doc. Doc, wild guess, Doc, about sa opacity, Doc. Usually, Doc, due to infiltrates, Doc.
Okay, infiltrates. Though some radiologists are using the word infiltrates, but actually current studies now that doesn't really advocate the use of infiltrates. Okay, now diba? This one I'm telling you that this is a case of pneumonia. Okay, when you have I say that this is a case of pneumonia because basically you have haziness or opacity here. Why do you think it's opaque? What made it white? Nga puti siya. Kung may pneumonia, nga aga puti ang lungs kung may pneumonia. Normally, ang lungs is, di ba, air, so that's why it's lucent. Nga kung may pneumonia, nagaputi. What do you think is the pathologic process going on that makes it white or opaque?
Ako yapon, Doc.
When you have pneumonia, basically, the problem actually would be at the level of your alveolus. So, anong kakatabo sa alveolus nyo? Nga nagputi na siya. The alveolus is usually filled with air, di ba? In a normal setting, in the normal setting. Pag may pneumonia, anong kakatabo? Who can help John? John, do you know the answer?
Why na ko idea, Doc? Sorry, Doc.
Okay. Who can help John? What happens in pneumonia? Yes?
Fluid build up, Doc.
Okay, good. So remember, the reason why we have opacity, it's because of the fluid content in those tissues. When you have pneumonia, your alveolar cells or alveolar sacs, instead of air, they are being filled up by fluid, by mucus, because of the inflammatory or infectious process. That's why, imbis nga itom nga air, nag-filled up sila sang fluid, that's why nagputi sila. So very good. So now, this is actually one way for us, one of the ways for us to check if there's a pathology. Kay kung kisa, hindi na siya tama ka siri, no? One way actually for us also to determine if there's really a pathologic process or if this opacity is pathologic would be to check for silhouette sign. What is that silhouette sign? Actually, it's a misnomer because when we refer to silhouette sign, we mean loss of the silhouette. This one, if you notice, the silhouette of the left cardiac border is crisp, well-defined. If you notice, the silhouette of the right cardiac border is lost. Hindi mo na siya ma-define. This is because of the superimpose, kaya hindi blaga sampaw-sampaw lang. Di ba? When you see this cardiac border, it doesn't only mean nga heart lang na ding area because part of the lungs is also superimposed in yung heart. So when you lose this border, you lose this silhouette at the right cardiac border, that means that there is an ongoing process which is most often fluid filled. That's why nga nadula ng imo nga silhouette dere. So this is actually loss of silhouette. So that's silhouette sign. This is quite really an important principle in radiography because it helps us confirm whether there's a pathologic process or not. Kaya kung kisa very faint lang, so what we try to check if may loss ng silhouette. The problem if you lose your silhouette or cardiac border nga silhouette would be hindi na naton ma-assess na ang imo nga heart. That's why when we interpret this, usually we would say that there's an hazy opacity at the right, middle, and lower lung zone, mostly on the paracardiac area, obscuring, meaning obscuring your right cardiac border, precluding adequate evaluation of the heart. So, hindi ta na mabalaan kung may cardiomegaly or wala because hindi ta na ma-assess ang heart. Okay, let's now proceed to cardiomediastinum. Terminologies and anatomy. So basically, the mediastinum is radiographically. Actually, ang problema ko ni is because different books would the division for the different compartments of the mediastinum would be different based on different books. But what I'm using actually is our Bible sa radiology, when it which is fundamentals of which is by brands, a book by brands, which I'm going to show you later actually the complete title of that book. But anyway, basically we have 4 compartments of the mediastinum. We have the anterior mediastinum, the yellow one, and we have the middle mediastinum, the red one. We have posteriorly the posterior mediastinum, of course. So basically, what delineates the anterior, middle, and the posterior mediastinum would be your heart. Your heart belongs to the middle mediastinum. What's anterior to your heart would be your anterior mediastinum. What's posterior to your heart would make up structures belonging to the posterior mediastinum. Then at the level of T4 and above, you usually have what we call the superior mediastinum. So actually your aortic knob and part of the thymus in the pediatric group and your upper trachea would belong to your superior mediastinum. So repeat, you have 4 compartments, okay, when we talk about mediastinum. So this is just another diagram of your anterior, middle, and posterior mediastinum. Usually, your posterior mediastinum would also include your spine or vertebral bodies. So again, applying it in radiography, the one between, the space between, or the structures found between the sternal silhouette here and the anterior aspect of your heart would belong to the anterior mediastinum. Then, of course, between the blue and the green one, that would be your heart, that belongs to the middle mediastinum. What's between the green line and the red line would now be your posterior mediastinum. That would include the ribs. And now, for the superior mediastinum, basically, who would find it at the level of T4. Actually, this makes up actually the portion of the arc of your aorta or your aortic knob. And on the other hand, that would this refers to actually, I'm sorry, the line should be lower. That would be at the round of T4. Yeah, correct. I'm sorry. This portion here actually now would be your superior mediastinum. If you notice, there's, I'm sorry. If you notice here, there's the arc of your aorta. So that would be the superior mediastinal area. So I'm going again to present to you the various locations which we refer when we're reading X-ray images. So the one in the yellow pointed by the yellow arrows would be your paratracheal. So that would be your paratracheal areas would be the right and the left paratracheal, because this is your trachea. This is actually your thoracic trachea. What's on the right of your thoracic trachea would be your right paratracheal area, and what's on the left would be, of course, your left paratracheal area. Then we have what we call the supramediastinal area. So this is your superior mediastinum, taken usually at the level of the arc of the aorta, and usually it measures around 6 to 8. But on my private practice or at any, whether when I read x-rays, I use the 8 centimeters as the upper cutoff. As the cutoff for normal. So when it is more than 8 centimeters, that means it is widened. Meaning, if it's widened, there must be a probable pathologic factor or a condition that's going on in the superior mediastinum when it's widened. Then we also have what we call the hilum. So we have the right hilum and the left hilum. Then, of course, we have the heart or the cardiac silhouette. We'll be discussing this one thoroughly as we go along. So again, if you notice, when you're doing a posterior-anterior view, that means the X-ray tube would be from your back to the front, or whether you're doing an antero-posterior view, meaning anterior to the posterior portion. If you notice, when you read a frontal X-ray, you wouldn't know which mediastinal compartment it belongs. Kaya di ba nag-superimpose? So if you have a lesion at this portion, when you just have a frontal X-ray, you wouldn't know anterior mediastinum siya. So let's now discuss how to narrow down location and structures involved. Just like this case. If you notice, you have a convex opacity at this area. Actually, it's more on the right hilar area and of course part of the superior mediastinum. Now, given this image, kay usually di ba ang gina-request mo lang sang doctor is PA or AP. The most we do here, actually, when we describe this, is that we have an convex opacity at the region of the right hilum, and extending into the superior mediastinum, causing also widening of the superior mediastinum. But with this, we cannot locate, and we cannot even either have a close differential for this condition or for this X-ray image. Why do we have differentials? Anong pag-intindi nyo when we talk about differentials? Hi, Beverly, have you encountered the term differentials? JP, I'm sorry, JP Beverly JP? Hype, I'm sorry. I don't. Hype, okay. Have you heard of the word differentials?
Yes, Doc.
What do you understand by the word differentials?
Differential diagnosis, Doc.
Yeah,
Possible
correct.
diagnosis.
What do you understand by differential diagnosis? Let's say may patient ka nga gaubo. What are your differential diagnosis if you have a patient who has a cough? Okay, let me help you with that. The reason I'm discussing differentials with you because X-ray is a very limited imaging modality. What I'm trying to say is that because nag-superimpose ang structure, nakita nyo naman ang mediastinum, may anterior, middle, and posterior. But when you're presented with just frontal view, kag may ara ka abnormality, you wouldn't know, di ba, kung ara siya sa anterior, middle, or posterior. That's why when we interpret X-ray images, given lang kami abi sang frontal view, we usually use differentials. So we just tell na, let's say na, right, primary consideration in this case is a right hilar mass, cannot rule out a vascular pathology. the reason for that, nga may differentials kami because kung ihatagan lang ta sang frontal view, because of the superimposition of the structures, we wouldn't know kung diin na siya nga portion, kag kung ano na siyang structure nga involved. So that's why nga, when you receive X-ray results, kung kis adamo-damo differentials, that's why we lead to recommendations such as CT or MRI studies to narrow down the differentials. Remember, X-ray or imaging is not histopathologic, meaning wala talaga studies ang tissues wherein we really clinch the diagnosis, no? Nga confirmative. There are though cases wherein X-ray is diagnostic or confirmatory na almost, but usually, may mga higher modalities pa. So, ang ginahambal ko lang sa inyo, Subong, is that pasensyahan nyo lang ang radiologists if they cannot give you confirmative diagnosis given certain pathologies presented with X-ray because it's really difficult for them to localize and identify kung ano ginaang lesions. So that's why usually we do differential or we just give you differentials or various considerations kung ano ina nga pathology. I don't know if you get what I mean, but later in the future, I hope you remember what I'm trying to say right now. Anyway, this one is actually a right hilar mass. If you notice, kung ako palang tawon, meaning may problema sa hilum. But actually, when you do a lateral view, this one is the portion of the hilum. And the mass actually is seen anterior to the hilum, not at the hilum. So when you, just like in pulmonary lesions, if you want to do some localization of the pathology, you still have to do lateral view. So very helpful gid gyapon ang lateral view. So some doctors actually, especially ang mga elderlies, current doctors actually usually would request lang NIP or AP view. One would be siguro to minimize ang radiations ng pasyente, at the same time ang cost, and just for an initial screening. But some, especially ang mga dugay na nga mga doctors or physicians, usually right there and then, they, especially kung naga high degree of suspicion with sila nga may mga cardiac or may mga pulmonary pathology, right there and then, they request actually for PA and lateral view. But nevertheless, this one actually, that means that the lesion is actually at the either anterior or middle anterior or middle mediastinum. Galing, actually, if you notice here, most likely involved gidya ang anterior mediastinum, no? Though actually it seems here to be centered in the middle mediastinum. But anyway, this is actually a case of thymoma. So this is a case of thymoma, and if this is a case of thymoma, most likely this lesion here belongs to the anterior mediastinal masses, given that thymoma is by nature coming from the organ of the thymus organ, which is located at your anterior mediastinum. So what I'm trying to say right here, right now, is that if we do lateral view and if we are able to identify whether the lesion is at the anterior mediastinum, posterior, or middle mediastinum, we can narrow now the differential diagnosis. Such as in this case, if it's an anterior mediastinal mass, it can either be a thymic mass, lymphoma, a thyroid mass, or a mesenchymal tumor. You would also have different differentials for the mediastinal, for the middle mediastinal and posterior mediastinal mass. So, I'm sorry, this one is wrong image. So now let me discuss with you actually what I'm trying to point out here actually is correct. This is not wrong. Let's go back now to your paratracheal area, the area at the sides of your trachea, even at the front or posterior to your trachea. That would be your paratracheal areas. So laterally, if this is your trachea, basically, your paratracheal, in this image, if this is your trachea, the paratracheal area would be at this portion. So at this portion, you also have your paratracheal area when you do a lateral view. if you notice, I will not ask question anyone from you, but if you notice, there's an opacity here from the right, both at the right and the left paratracheal area. As it seems, this opacity at initial mga lantaw, the opacity actually seems to be at the level of the superior mediastinum and at your right and left paratracheal. But actually, if you do a lateral view, if you notice here that the trachea is anteriorly displaced, so dapat ang trachea ari na di. It's anteriorly displaced such that your prevertebral space, that would be the space between your trachea and your vertebra or spine, is widened. Ideally, ang space between the trachea and your spine would just be equivalent to one vertebra. So if you notice, this is your vertebra and if you place another vertebra here, meaning nag-exceed ang iyang size sa isa ka vertebra. So this space here between your trachea and your vertebra, which is called the prevertebral space, is widened. That means the problem here actually is not necessarily at the sides, but also posterior to your trachea. So this is actually a case not of a thyroid mass which extended into your retrosternal area, but this is actually a case of an abscess which envelope actually the which actually is located at your prevertebral space. So it pushed your trachea anteriorly. So this is actually a CT scan. You know where the lesion is, and it's actually associated with lytic lesions, meaning nag-erode ang imo nga bones. This is a classic picture actually of tuberculous spondylitis with prevertebral abscess. So what I'm just trying to point out here is that though this appears to be at the sides of your trachea, this lesion actually is behind your trachea or posterior to your trachea. This is the problem actually with an X-ray wherein there's superimposition of the structures. It's really quite difficult for us. Amo na siya actually take away message ko sa inyo nga when you have X-ray, very limited actually man ang ma-derive nyo nga data or information from the image. That's why radiologists who sees this image would suggest usually that a CT scan or MRI should be done to further clinch the diagnosis. So let's proceed now to your superior mediastinum. So as I've said, the cutoff is between 6 to 8. I'm using usually the 8. Actually, safely 8 gid siya, no? So this is a case wherein you have a widened superior mediastinum. And I want to show you what are the contents of the superior mediastinum. So actually in your superior mediastinum, you have the distal portion of your ascending aorta, your aortic arc, and this one is actually what we call the knob. At the same time, radiographically, this is what we refer to as aortic knob. And also part of your superior mediastinum would be your main pulmonary vessels, main pulmonary artery. The blue one actually, I'm sorry, for a while. Part of the superior mediastinum actually would be your superior vena cava. So this is your right internal jugular vein, left internal jugular vein draining into your superior vena cava. This is your subclavian and subclavian. But basically, you have your aorta, you have your superior vena cava. At the same time, you also have your main pulmonary arteries, which belong to the superior, what they call this as superior mediastinum. If you're a child or if the patient belongs to the pediatric, a neonate, a newborn, you also consider presence of thymus. Part of the upper portion of the thymus also can be seen at the superior or extends into the superior mediastinum. What I'm just trying to say is that when you have enlargement of the superior mediastinum, usually what comes into the mind of the radiologist would be there's a possible pathology going on with the great vessels of the mediastinum. So when we talk about great vessels of the mediastinum, particularly we're talking about the blue one, which is the superior vena cava, the aorta, and your main pulmonary arteries, which is seen here in the gray portion. Though of course you can have also lymph nodes here at the same time. You can also have other masses in this area, including subcarinal masses or masses belonging to the pulmonary system. But nevertheless, so if you notice, you have a superior mediastinum here, which is widened. So this is the aortic knob, but if you notice, there's an extension here. So this is by eyeballing a superior mediastinum, we did a lateral view, and it just showed here that actually that your aortic arc, and in particular your descending aorta, which is actually widened. So this is actually a case of aneurysm. So if you have superior mediastinum widening, usually the radiologist or you as clinicians later on, please do request for a lateral view so that we would be able to further come up with a closer diagnosis. So whether it be vascular or a mass lesion, we would be able to somehow better delineate or adequately assess it if we do a lateral view. So this actually represents. Now let's proceed now to the hilum. So that's your right hilum and the left hilum. Please remember this word hilum because most often radiologists are using this area or structures. So when we talk about right hilum, basically we're talking about the area wherein you find a cluster of vessels and structures related to your airway. So you have the right main bronchus, the left main bronchus. For the right, you have here you have the right main pulmonary artery, then you have the left pulmonary artery. You also have your pulmonary veins. As you know, you have 4 pulmonary veins, 2 at the right, 2 at the left. That would be your superior and inferior pulmonary veins. So basically, your right main bronchus, your main bronchus, your pulmonary arteries and pulmonary veins are the main structures which you usually find in your hilum. And of course, on top of that, you would also find the green ones, which are your lymph nodes. So this is a picture of your right hilum. It is different from your left, especially when we talk about the airway, because as you well know, for your right, you have the right upper lobe, right middle lobe, and left right lower lobe. On the other hand, on the left, you just have your right upper and your left lower lobe. That's why ang bronchus mo, diri sa right, your right main bronchus is divided actually into your right upper bronchus. This one is your intermedius. Your bronchus intermedius, actually, it's the one who is giving branch to your middle and your lower lower bronchus. On the left side, you wouldn't find your bronchus intermedius. Please remember that it also sometimes comes out in your PLE. So ang bronchus intermedius nyo is just at the right because this one is the one that branches into your right, the middle and the lower lobe bronchus. Anyway, going back. So this is your right hilum. So the right hilum actually, as I've said, is made up of your right main pulmonary artery and at the same time, your what do you call this? Your veins, your superior, inferior veins, and your right main bronchus. In particular, your right main bronchus. This one is for the left. So if you notice the difference between your right is that the left main bronchus just branches out into your upper lobar bronchus and your left lower lobar bronchus. So wala ka na siyang bronchus intermedius. So this one actually is, then actually ang difference pa na nila may ara na sila sang ang difference in the orientation of your pulmonary and bronchus, which I'm not going to discuss with you anymore, but because that's too detailed. But just to recap, this is your right hilum, that's your left hilum, and laterally, that's that's where your hilum is located. So basically central portion, upper portion of the mediastinum, and it's usually posterior to your heart. So this is actually a case wherein you have an opacity in the right hilum. In the rest of time, hindi na ako mamangkot sa inyo, but this is actually opacity at the right hilum. When we did a lateral view, it showed here that you also have a opacity at the right hilar area. Actually, this is a case of hilar lymphadenopathy. Bali, ini siya, ang haziness is actually due to a lot of lymph nodes which are enlarged secondary to a Cox infection or primary PTB. So actually, in the pediatric case, sa mga pedya, sa mahilig magpedya, or those who are planning to go into pediatrics, it's really quite seldom that patients with primary tuberculosis would present with parenchymal lung lesion. So it's very seldom may mga opacities ka na din, no? Or daw mga pneumonia or TB looking na opacities sa parenchyma. Usually what we're looking, if you're considering a primary TB, would be enlargement, usually unilateral lymphadenopathy, unilateral hilar lymphadenopathy to be exact. So when you see pediatric cases presenting with unilateral hilar lymphadenopathy, you already do a Mantoux test. Most likely it's a case of primary TB or Cox infection. And of course, anyway, when you do pedia, usually they request APL for pediatric group, which I'm going to discuss later. So this is actually another case wherein identification of the level of hilum is important. Actually, na-discuss ko na sa inyo gay na, di ba? So if you notice, in this case, the right hilum is elevated. This is how usually we describe it. So there is somehow right tracheal deviation, and the right hilum appears elevated. Nakambal ko elevated because if you notice, the level of your left hilum is same as the right. Remember, the right hilum can never be equal to the level of your left hilum. If it's already equal, that means there's some sort already of right hilar elevation. So this is a case actually of right upper lobe collapse with concomitant or associated with right hilar deviation. And if you notice, there's also an elevation here of your right minor fissure because of the collapse. This is what we classically refer to actually as in radiology as the golden S sign. So usually this golden S, because of this one, it's actually discovered by golden. The sign is discovered by golden. A case wherein upper bronchus it is unstable. May law. Dula na. Can you hear me now? Am I in? Okay na ko?
Yes, Doc. Yes, Doc.
Stable yapon. Oh my God, the internet connection is terrible.
We can hear you na, Doc.
Okay na? Can you hear me?
Yes, Doc.
Carm, can you hear me?
Yes, Doc. We can hear you now.
Okay. Terrible, gina nga ako ng internet connection. Is there, may free time pa ka mo next week? May bakante ka mo nga next week. Ideally, gabi. Ang
I
connection ko is really irritating.